Hi, and welcome to our episode about psychiatry with Dr. Nyota Pieh. Dr. Pieh, thank you so much for being here.
Thank you for having me.
Now, I really want our listeners and watchers to know that this is an ultra special person. And Dr. Pieh and I have not only been friends since we were literal teenagers, but
Yes.
she was the person who contributed the mental health tips to my book, Prescription for Admission. And she's done a really excellent job informing people about what they need during an acute hospital stay to maintain their mental health, ask for help with their mental health, and also advocate for the people who they love who are hospitalized. And so when you grab a copy of the book and you see Dr. Pieh's Corner, this is Dr. Pieh. So this is an ultra special event for me to have her here to speak directly with us. So double thank you, Nyota, for being here. So tell us, when people think about psychiatry, they don't think about acute medical hospitals, right? In the media, in people's minds, psychiatry, and also logistically, tends to live in a different setting. But you can't divorce your mental health from your physical health,
Absolutely.
right? And we do know that people who have an underlying primary psychotic disorder or psychiatric disorder also tend to have more complicated medical outcomes, right? And then medical outcomes can cause complications with your psychiatric, psychotic, anxiety, depressive, addiction, all of that. So there's no divorcing it.
That's
So psychiatrists like you who work in medical hospitals, tell us, what is that like and what drew you to this work?
First, thank you for having me. I was excited to talk about this area of psychiatry because, as you mentioned, it's not necessarily what people think of in terms of what a psychiatrist can do, but it's a really exciting field. And it really shows, I think, how psychiatry is very much a part of medicine. I always tell people we are physicians, we go to medical school, we have to take our board exams and for the step exams. So we are physicians. And what's really, I think, interesting about this space is you really get to see, as you mentioned, how essentially the mind and the body are connected. So in the acute sort of psychiatric space, and this consultation liaison is the term that's being used today in terms of this area of psychiatry. It used to be called psychosomatic medicine, but that's a little bit of a misleading term. We do focus in the area of psychosomatics, but it's not just psychosomatics. But essentially, when you work in the acute hospital setting, I always tell people it's on the medical side of the hospital, not the psychiatric side of the hospital. And we see everything from people who come in for surgery and they have depression, and the surgeon wants to know if we should continue their antidepressant, to assessing for capacity to make decisions about whether a patient can consent to care or to refuse care. We work closely with palliative care and hospice at times. We work in the ICU. So we work across essentially every area of the acute care setting. We also work closely at times with social work and work on discharge planning. So we also think about how do we help people transition back home from their acute care stay. One of the things that I would say is really important to think about when someone asks, well, why would a psychiatrist need to be involved in this type of work? It's stressful when you go into the hospitals. I think that's the first thing is, whether you have pre-diagnosis coming into the hospital of anxiety or depression, or you're just stressed or something happens while you're in the hospital, it can be a really stressful time. Psychiatrists can be there to help advocate for patients, advocate for family, sometimes also support the staff. So the hospital staff often also are having to, take care of really sick patients, and the psychiatrist is also there to support them as well. So we do a lot of different things that I think often don't get seen in the hospital space. I like to say we are kind of the behind the scenes position that really connects a lot of parts of the hospital together.
Yeah, and that's what this podcast is about, is what's going on behind the scenes that people aren't seeing, who are the people caring for you. And you've touched on some really big things that I want to talk about. The first that I really want to talk about is capacity. So for our listeners, when you come into the hospital or any medical space, there's often the assumption, if you are of age, that you can make your own decisions, right? But if there comes a point where the team is questioning, like, is this person really able to make these decisions? This is when we just decide we need to have a conversation around capacity. Nyota, can you explain to us what is capacity?
I think in the simplest way to think about it, it's the ability to make an informed decision, to demonstrate that you understand not only what the choice is that you're being offered, what the decision is about, but that you're able to actually take the information in to make a rational decision, even if it doesn't necessarily align with what someone may recommend you do,
Right.
but your ability to essentially demonstrate that you understand what's being offered, that you can weigh the pros and the cons, and that you can essentially make a decision that is not coerced in any way and is really of your own free will, essentially.
Yeah. So there could be lots of reasons why people lack that ability. And when you come into the hospital and you're sick, one of the things that can happen is you can get confused,
That's
right? And we call that confusion delirium, right? And this is saying that you are confused, you're not in your right frame of mind. You may not even be alert enough. That may be an issue that you're sometimes alert, sometimes you're not alert because you're medically sick, right? But there are other reasons that people may have problems making their decisions. But something that I find families struggle with is when we actually say, no, someone has the capacity to make decisions, and family members may not like that decision, right? And so how do you navigate that? Somebody may be a little bit off in lots of ways, but the decision around capacity is really oftentimes around a decision, right? Do you want to have this surgery? Do you want to take this medicine? And somebody may have their own reason that their family members may say, like, well, they really need the surgery because without the surgery, X, Y, and Z won't happen. But then they may say, like, I don't want the surgery because it might hurt too much. And that's like a legitimate reason to not have a surgery. So how do you balance that as a psychiatrist?
Great question. I think it's one of the more challenging scenarios that can occur in the hospital space. So I would say the first thing is to make sure that everyone has a really good understanding of what is being recommended, and before the recommendation, what the patient is coming into the hospital with.
Right.
I think that's the first. I think just providing information. And as a psychiatrist that's being consulted, I often want a hospitalist or the surgeon to be there with me to make sure that everyone, including myself, is on the same page about what are the symptoms, what we're concerned about, so that there's real clarity in what's being communicated. And then I'll have a conversation first with the patient to understand what are their concerns. What are their wishes? What are the things that they want to avoid? Are these things that are realistic in this medical space? Are there implications downstream if they refuse something? So we'll have a conversation around those topics. And then I'll usually bring the family in to hear them as well. But I think it's really important to first give the patient, who's the patient, a space to speak. And then we'll talk with the family. And then we'll kind of try to parse out where there may be differences of opinion. And I think it's important to acknowledge when families have concerns, what they are. Sometimes it may be that they're concerned about the impact it'll have on their life when the patient goes home.
Yeah.
And so we really want to try to explore all of those things first. But as you mentioned, capacity is around a single issue. So people can have capacity for one thing and not for another thing. And so I think that's the other piece that's really important to explain to people when we're in the hospital is to say, yeah, I understand that you have general concerns about how your mom is at home, but she's able to actually take in the information that we've shared, and she can provide a rational decision for a reason for her decision. And while it may not be something that we might agree with or that we would choose for ourselves, she really leaning into the idea of autonomy. She is able to make that decision. And so really being able to help people understand that might be for one specific thing. And these are the alternatives that we can consider, even though we may also be able to acknowledge that we do notice there may be concerns in other spaces. So sometimes that's the approach we'll take is really just, I think taking the time to hear somebody is the first step.
Yeah.
And acknowledging like, yes, this is challenging and this is something that we will have to consider. And so what else could we put in place? And that's, again, where I often will pull in using that multidisciplinary approach, whether it's someone from social work or dispo planning or their outpatient primary care physician to see how we can support them once they leave the hospital.
Yeah. So I really want people to understand that because in the space of hospital medicine, things move fast, things move quickly. People change their minds, but also someone's mental status can change multiple times during a hospital stay. And so how you're working with the team and with the patient to make sure that you're really honoring their wishes throughout their hospital stay, be it that they have capacity to make this decision, or if you're their healthcare proxy because they don't have the capacity and you are there to support the wishes that they have told you about in the past. And so working with your psychiatrist in the hospital to say like, hey, I'd really like to talk to the psychiatrist because we just don't feel like mom or dad or my husband or whatever has capacity to make this decision. Can we have a conversation about it? I think is something really helpful for people. Now, the other thing you touched on is all the different spaces that psychiatrists work in acute medical hospitals. And you specifically mentioned ICUs, right? So that's not a place that people think of psychiatrists being, right? But having done my fair share of ICU work as a resident, it's a space where you are often called on, right? What does working in an ICU where there's lots of people think of it as like machines and intubation and things like that. Family members are often surprised to see a psychiatrist show up in the ICU. What does a lot of your work there look like?
Great question. I would say I always, again, like to think of myself as an advocate and hopefully helping to provide clarity and support for a good outcome for the patient. So we will be called at times. Capacity is a very common consult, whether it's capacity to, again, refuse treatment, capacity to, they just want to make sure that they're consenting to treatment, when someone's really sick, that they understand on. And so just another layer of, yes, we really think this person is able to consent to procedure or treatment. Another common that will occur is with when someone is intubated and maybe is delirious and what we would consider agitated. And so we really will work with the team to address that agitation. And when I say agitation, I don't mean that they're just being mean patients. It's really because of what's going on in their brain. And so we'll work with them and recommend specific medications that can help that agitation and really essentially keep the patient safe. And I think this is really another place where not only with the patient directly, but also with the family, helping them to understand what's going on and to help advocate and say, we want to recommend this medication that will help keep your family member calm and safe, essentially, so that they can be adequately treated. We work closely in the ICU with, I would say, all of the staff. So not just the physicians, but I think this is where having a relationship with the nursing staff is also really important because we, whether it's agitation and they need to administer a medication and we need to observe that, or we want to be there to see how the patient responds, having a good relationship with all of the ICU staff, I think is really important in that space as well.
Yeah. One of the things that brings people to the hospital that can be where that mental health and physical health meet are suicidal thoughts, homicidal thoughts, or attempts. Addiction medicine is another space that we really see this where we need the support of a psychiatrist to help us navigate that space. And oftentimes when patients are coming in with these comorbid conditions, because medical illness can often come from addiction, and then suicide attempts can sometimes cause injury and illness and things like that. If these patients aren't particularly safe to go home, what do you do and how do you think of helping them after an acute hospital stay?
Great question. So when someone comes in, we first, and particularly if they're medically unstable, we need to make sure we stabilize them medically. And at the same time, work on trying to figure out a plan for them. So we will try to work in parallel as much as we can with the hospitalist or the surgeon, depending on what the injury is. But once someone is medically stable, we will make a decision as to whether they're safe to go home or not. And the things that we would consider are really Are they still having thoughts of wanting to hurt themselves or hurt others? Are they able to safely care for themselves? So in addition to being suicidal, someone may be psychotic, or you mentioned addiction medicine. Are they in acute withdrawal? We need to make sure they're stable, continuing to maintain stability for them to safely transition back home. Sometimes we'll do something such as a step down to an intensive outpatient program or a partial hospitalization program where they technically sleep at home, but they're in a program during the day. So that is a slightly less restrictive environment than an inpatient psychiatric unit. But we do consider, and we often will, transfer people from the acute medical side of the hospital to an inpatient psychiatric unit if there's a concern for ongoing safety. And so we'd again essentially assess whether they're at acute risk and things that we ask. And so what's really helpful is it's best when psychiatry is called early in an admission so that we can kind of see the trajectory. And we'll also help talk about things like, are they in pain? That can be a really big reason why people, or discomfort, a reason why people might continue to say they're suicidal. And I mean physical pain. So has their pain been managed? Do they have other care needs that we can work with the social worker, someone in the outpatient setting to set up so that they have a smooth transition home? Some of those things are also important to identify as we're thinking about just general safety, because that can make somebody feel like, well, I have either more to live for, or I'm not going back to the same circumstance that I was in before. So we really, again, work multidisciplinary, but we do consider at times whether to transfer someone to a psychiatric unit or some other type of step down, such as partial hospitalization or intensive outpatient program.
So what does that look like to get to an acute psychiatric hospital? First, I'm asking a leading question because I want people to hear this. How much access is there for patients to have to acute psychiatric care?
Yeah, very good question. It's not easy, and it really depends on a few different factors. So the first I would say is availability of a bed. That's probably the first thing.
And how available are these beds?
Not very available anymore, unfortunately. It is not easy to get someone to another hospital, I think, or to an inpatient psychiatric unit. I think it's helpful if you're working within a system that has an inpatient unit. So there are many hospitals, particularly larger academic hospitals, where they may have an attached psych unit site. It's the easiest, I think, way to someone into a psychiatric. If there isn't one attached to the hospital or affiliated with the hospital, then you're looking at going outside of the system. And so it really, again, requires working closely with your the unit caseworker or social worker. We call it discharge planning. And we will to call hospitals. We will start looking at your insurance to see which hospital, because we certainly want to consider cost. And it's safe to say most people have to pay out of pocket for an inpatient hospital stay. So we always want to make sure that we're considering cost and working with your insurance to find a bed that would be considered in network. And then, so that's one thing. And then they have to have the availability. And then you're also looking at whether the patient is going to be hospitalized voluntarily, meaning they're going to agree to go and they're signing themselves in essentially as a voluntary admission. Or on occasion, we have to consider what's called an involuntary hospitalization. And that is really state dependent on what's required for that. So when I was practicing in New York, we had something called a 2-physician certification, meaning you had to have 2 physicians essentially attest to the need for that involuntary stay. And that would get the person transferred, and it gives you a number of days to really work with the patient. And then you can petition the court for longer stay. So there's a lot of systems involved in getting someone to an inpatient unit.
And it does vary state by state. So when I was in California, they called it the 5150, which was an involuntary hold for 72 hours, and then the 5250 if it was going to be longer. Here in Massachusetts, it's a section, they call it section 13. But so these laws all vary state by state, and availability of psychiatric inpatient facilities also vary state by state. And as you were saying, insurance by insurance. And there's a dearth of inpatient psychiatric care, and patients can often wait a long time to be transferred. And so I know, like, medically, we try to bring psychiatry in early if we feel like, oh, this patient is here for something that may need an inpatient psychiatric stay, so that even if they're not like 100% ready, just getting them on a list, because it's going to take several days by the
Absolutely.
time that, they get to, they're kind of in a different space and they may be medically much more appropriate for that place. But having the conversation and starting the better early, because I have had to unfortunately send patients pretty far away from home to get care. And that's isolating for the patient and their family members and loved ones who may want to visit them and be supportive. Yeah. So I know that was leading, Jen.
Yeah. It's a good question. I think there's a lot of, I think it can be frustrating when someone's waiting for a bed and not understanding there's the complexity that's there, and the things you kind of have to navigate and the timing of things. Yeah. I will also say sometimes when we have those long waits, the psychiatrist will continue to see and should continue to see the patient and treat them. And so there have been, and so there are times when, by the time the bed becomes available, the patient's actually able to go home.
Looks different.
Yeah. So, and that's why it's just, important to ask for psychiatry, ask them to come back, to have a plan of, getting them connected to care, just so that patients not just sitting waiting, because that's time that they could be getting treated.
When would you suggest a patient or family member ask to see psychiatry? Because on my end, as the hospitalist, it's either when I say, I think we're going to call the psychiatry team and come by and chat with you, people are either used to seeing the psychiatrist and say like, yes, okay, I'm fine with that. Yes, I want them here. Or this happened to me not too long ago when I said, I'm going to, your mother's delirious and I'm really kind of concerned. And this person's loved one said, my mother doesn't need a psychiatrist. She's not crazy. She's just a little confused. And I tried to explain that in the space of acute delirium in the hospital, this is really where psychiatrists can be of really great help to me medically. And this person was really really unhappy at the idea of me having a psychiatrist see, their older parent. So when would you suggest that family members or patients advocate for themselves to see a psychiatrist in a medical hospital?
So I think it's always good to first talk to the hospitalist treating your loved one or yourself as a patient and say, this is what I'm noticing. I think confusion is often the most common thing that I've seen in that space. And so saying exactly what you've just mentioned, I'm confused, maybe the hospitalist has tried things that haven't worked. And we want to make sure that, and just saying, this is not my loved one that I know. If you recognize that they seem confused, they seem off, they're just not themselves, there's a high likelihood they're delirious, particularly if they're more acutely ill, if they're elderly, if they had recent surgery. But don't also discount younger people because they too can become delirious. I would also say we often get consulted, or we often get consulted when someone is delirious and agitated and they need to calm down. Mm-hmm. But you should also be wary of the person who is just really sleepy and they're kind of slowed down and sluggish. That's another type of delirium that can present and often go missed. So anytime you just feel like your loved one is off, I think the first stop is or the first question, and I would say, ask the hospitalist, do you think it would be helpful to call psychiatry? Additionally, if there are medications that were stopped for surgery or for procedure, or you're concerned about a side effect, do you think it would be helpful to call psychiatry? And then, I think it's important to have that. The hospitals will have to be the one to make the consult, but you can certainly request it. If you're in a space where you feel the hospitalist or the person treating your family member or yourself is being resistant to that and you really want to see the psychiatrist, then I think patient is another great option, to explore. The patient advocate is there to advocate for the patient and often can be a nice intermediary between the patient and the hospitalist, just in terms of helping everyone understand like what the concerns are. Yeah. But I think anytime you have a concern, it's always worth it to ask. And as you mentioned, psychiatry, unfortunately, I think we get that statement, I'm not crazy. I think the best way to think about psychiatrists, particularly not just in this space, but particularly in the acute care setting, is we're actually mostly dealing with people that have confusion and cognitive issues, even more than just depression. That being said, things like anxiety and depression can also contribute to cognitive issues. Mm-hmm. So this is our wheelhouse, and our goal is really just to help advocate. We very often are not sending people to psychiatry. We're really supporting them in their journey in the acute care setting, medical setting, and they're able to be discharged home. Oftentimes, when you get psychiatrists involved, that can actually shorten length of stay. I worked in a hospital setting where we really tried to be proactive in our consultations and identifying people who are more likely at risk of having delirium, just because we know that the earlier you can intervene and just support the other physicians that are managing you, that it can shorten your length of stay.
Right.
So
delirium I'm so sorry. Delirium will increase your length of stay, the amount of time you find yourself in the hospital, but it can also be a harbinger of bad things to come.
Yes.
Right. And so people who experience delirium, which is, again, that very abnormal mental status, and like Nyota was saying, wakefulness, right? Oftentimes they're awake, they're not awake, or they're just really kind of drowsy and out of it all the time. People who experience delirium can have higher rates of what we say morbidity and mortality, meaning more complications or more likely to pass away, right? And so it is not benign to have somebody experience delirium. So as an acute care psychiatrist, what are your top 2 tips for patients and their family members when thinking about their mental health in a hospital stay?
Okay, the first thing is understand why you're in the hospital, what you're being treated for, what the recommendations are. I think that just being informed is key, and not being afraid to say, I need to talk about this again so I make sure I understand.
Yeah.
I think there are generational reasons why that doesn't always happen, or cultural reasons why that doesn't always happen. Some people just, the doctor says this, that's it. But if you don't understand, it's okay to speak up and say, I just need to discuss it with you so I understand. So that's the first thing, is you want to be informed. And then I think part of that too is being able to say, I'm scared. A lot of when people are refusing things, it's just because they're scared. And that's a reasonable thing. It is scary to be in a hospital, especially if it's your first time. Maybe if it's your 5th time. It can be really scary and you're sick. And it's a stressful time. I would say just with that, having other people that can advocate for you. So family members, I think this is where we're just saying, the person that can say, this is not my mom. I know how my mom normally is, or she was just normal, or she was just herself
2 days ago.
This is not her.
Yeah.
That is really helpful information. And so being able to have somebody that kind of knows you well, that can also speak for you, is helpful. And then also they help anchor you. So if you have that familiar person that's coming to visit, a familiar face, if someone is delirious, a familiar face can really help anchor somebody in the here and now. So just having those people around you that are, I would say, not causing stress. So the stressful, I know that we have a lot of loved ones that sometimes their intentions are good, but if they're stressful, that's not necessarily what we want. But if you have somebody that can speak for you and advocate for you, and also just be a familiar face, that can go a very long way.
Yeah. Stop by and visit your loved ones. Like Nyota was saying, something that I find often is like patients who are experiencing delirium may not cooperate or do something for the nursing staff or the physician, but they'll gladly do it for their loved ones. And one of the things we see is like eating and drinking. We'll say like, he hasn't eaten, and then somebody's daughter will come by and feed dad his dinner and he eats it. And that helps a lot. Those things go a long way. So be an advocate and visit and let us know what your loved one looks like, because it's a huge boon to us. So I always like to end on this question, and you and I were kind of batting this around. If you were to pick a TV show, a movie, something that best or worst shows your profession as a hospital-based psychiatrist, right? Which one would it be?
Presented very well.
Yeah.
People have very strong ideas of what they think a psychiatrist is, how they look. So I can't think of a specific show, but I feel like in most shows, the psychiatrist is kind of like hairy, just like hairy, like their hair is all over the place. They're just frazzled. They're a little disheveled. They're a little odd. And I would say that is actually not typically the case. Psychiatrists, I think particularly those of us that work in acute settings, we pride ourselves on, our ability to actually connect, because we have to connect with a lot of people in a lot of ways in very difficult situations.
Yeah.
So I would say my wish would be that you would show, I could, when I trained in New York, you knew the psychiatry consult team was coming. We would, we were always very appreciated in the hospital and very friendly. And I think a lot of it was because we've had to learn how to navigate. There's the whole liaison space of the consult psychiatrist, where it's really about connecting and liaising with others. And so, so I would say I can't think of one specific show, but most shows tend to show us as kind of being just all frazzled. And that's just actually not how we are.
One of the shows that I love for how it shows professions is Scrubs. And I think anyone's medicine. But I actually really disliked the psychiatrist on Scrubs. Like what you said, they portrayed her as almost like a walking joke. She would walk into a space and, oh, hi. She was supposedly not supposedly, she was very smart, and they would have these insights where she would say something and everyone would be like, wow. But then her personality was one of rainbows and butterflies. And then, there's the OG medical show, ER, which when I'm talking to med students, they like to age me. They're like, oh yeah, I've seen my mom watching that with my grandmother. But the psychiatrists, they had two, and I don't think people really remember them, but one was a very broken person who had their own, mental health issues. And then the second one, her story arc was really quite professionally disconcerting. So I want to say, in appreciation of psychiatrists, Dr. Pieh is right. When physicians are often talking, one of the things you will hear oftentimes is, what does psych have to say? Can psych please weigh in? Somebody please call the psychiatrist, because getting that space is very important. And the medications are not something that should be stopped lightly, restarted lightly. They come with their own medical complications as we're dosing antibiotics, as you're having surgery, making sure that you can still tolerate them. Dressing somebody's sleep is not benign, right? One of the, and so when the psychiatrist comes by and says, the patient needs to get more sleep, we're like, yes, okay, let's do this. All of these things are really, really important. So in appreciation, and if I ever write a TV show, I'm going to grab you and we're going to get it right.
Yes.
And they're going to be
fabulous psychiatrists.
They're going to be impeccably dressed and the leader of the team.
Always well dressed.
Always well dressed. Yes. They're always kind of kooky. And these are the people who are caring for the most intimate parts of us, which is ourself. Mm-hmm. Little known secret is that I actually started as a psych resident, right? Remember when I was at UCSD? Yeah. And one of the things that drew me to psychiatry is the treatment of self and how you identify and how you feel about yourself and move through your world, and that's something that I still really, really respect about psychiatrists, is that you're treating the mind, the heart, the soul. So thank you for your work. And thank you for joining us. And again, please, everyone, remember that Dr. Pieh, she's the one who contributed the mental health tips to this book. My very nicely put together display slid down in the middle of our conversation. So I had to reach and get the book. But Dr. Pieh's Mental Health Corner is, to me, one of the most vital things in this book, and something that has set this book apart from others, that I'm very, very proud that my longtime friend, can contribute to this and contribute to this conversation, and that you guys get to meet her and all of her brilliance. So, Dr. Pieh, thank you so much for your time. And listeners, thank you so much for joining us today on Prescription for Admission.